Carolyn, the floor is going to be yours in just a minute. And it's going to be a great story. I know it's going to be a great story because I had a sneak preview yesterday. But before I pass you over to Carolyn, I'd like to tell you a little anecdote about the time just before and when Carolyn, or the time that led up to Carolyn arriving here. So I used to work in the cancer epidemiology unit, and in the next door office was my great friend David Foreman, who left to take up a professorship in Leeds. And at that time I was studying radiation epidemiology in its traditional sense, so things that basically trying to quantify the amount of cancer caused by radiation. So that's how David thought of me. And after he'd been in Leeds for a while, he phoned up one day and he said, "Oh, I've got this lady who wants to do a PhD and she absolutely must have you as a PhD supervisor." So I said, "Oh, David, I'm not doing that kind of radiation anymore. I don't want any PhD students," and put the phone down. Anyway, a week later, he phoned me back again. Same conversation, put the phone down. 2 weeks later, same phone call. And I was so fed up with David, although he was my very good friend, that I said, "Oh, all right, she can come and see us. I'll talk to her." And it just happened about a day or two afterwards, and before Carolyn came down, Paul McGale, where's Paul? He's upstairs. Said, and I were trying to work, we were analysing data from randomised trials of radiation versus no radiation in breast cancer patients, and we were having real trouble understanding an excess mortality we were having from heart disease, and we could see it was clear grade 1 proof. But we couldn't take it any further. We borrowed Colin's anatomy book and we were holding it up and trying to find out where the heart was and how much. And we thought, Colin and I looked at each other and we said, what we need is a radiation oncologist. And the rest is history.
Oh, great, thanks so much, Sarah, for that introduction. Now, it's really nice to be here among so many friends, so thank you very much for coming. And also lovely to meet some new people as well. And when Rory asked me to do this talk, he told me to tell the story of how I got here. So this talk is going to be a story. There's some science in it. There's some things that I learned on the way. Many of you are in the story, so you might come across yourself in my slides. So all good stories have number points. So we'll start off with the early years, and second we'll talk about the clinical years, what I learned in the clinic, what the good bits, what were the bad bits, and then number 3, the great meeting of oncology and statistics, and what we have achieved together. And then finally I'll look into the future and talk about where we go from here. So first of all, the early years. Here is me, age 10. Now, by age 10, I had already decided what I was going to do for my career. I decided I wanted to be a doctor, and I had a very specific career aim. So I was going to train in medicine and go and work in Africa in a mission hospital. So I set out to achieve it. And I did the sciences in school. I really enjoyed my school years. And I then got a holiday job when I was 16 that helped me. So, age 16, I went to the Royal Marsden Hospital in Sutton, where some of you have worked. And I got quite an unusual holiday job. I worked in the mortuary. So, my role was to work one-to-one with the mortuary technician. And each morning I got up at 5, we started work at 6, and we had a list each morning of all the patients that needed a post-mortem. So we got them out one by one on the tables, and then we cut them open and took all the organs out. The liver, the brain, the heart, the gut, which was very long, several feet long, and we sliced them all up. And what we did was look for cancer. And it gave me a real appreciation of what cancer looks like, what it feels like, and where it goes. And in between cases, with all the bodies laid out, we'd drink coffee, eat croissants. And in retrospect, it was a slightly unusual job. I don't think it would be allowed nowadays, but it taught me a great deal. And actually, I've used a lot of the knowledge that I gained from that job in research over the past few years. So I applied to do medicine, and I came to Oxford to study it, Oxford Medical School. And initially it felt quite odd. So I went to an all-girls state school, and my college in Oxford was Christchurch here, and that was the last college to take women. And at the time, it was 80% men, and most of them were private school educated. And so it was a shock to the system, but actually I loved being surrounded by all the men. It was really fun, and I soon settled in and had a good time. And so here I am, trying on the scrubs for theatre. So this over here is the John Radcliffe Hospital theatre suite. This is our first time getting on scrubs to go into theatre. And this is me and my best friend at the time, Beth, who is now a GP working in Oxford. And one thing that we found in Oxford Medical School was that lots of people were very competitive. It really mattered to get top marks. It really mattered to do well. But we just weren't. We really enjoyed it, but we weren't competitive. And so it was nice to have kindred spirits. And we actually did a lot of our work in the pub. So this is the Butcher's Arms around the corner. And this is us revising for our obs and gynae exam, doing role plays in the pub. And it's actually a really painless way of working. And now, in fact, when my daughter has a particularly difficult bit of homework, we take it to the pub. And it really doesn't feel as bad. So those were some of my Oxford Medical School years. And I did a lot of rowing. So this picture is for the rowers among you. That's me at number 4.
And in the boat.
You can probably spot what's about to happen next, Johanna. There is the splash of the oar of the boat that's about to bump us, and the cock's looking over his shoulder. So I did a lot of rowing. We weren't very good, but it was fun. And then in the final year of medical school, we all do something called a medical elective. And that is where you try out your career ambition. And so my long-term plan was to be a missionary doctor in Africa. So I went to work in a very small mission hospital, Kizizi Hospital in southwest Uganda. Now, it was very deprived. There was lots of AIDS, malaria, gunshot wounds, wounds from lion attacks, very unlike Oxford. And these are some of the nurses who taught me so much. They knew so much more than I did. And I learned a great deal from them. And that's them on the women's ward. And this is the dysentery ward. One thing about Kizizi is that you never turn people away. And what that means is that you just pack more and more people into the small available space. So you'll see there's patients in the beds, but there's lots of patients on the floor. And when we ran out of floor space, you can put patients under the beds as well. And so that meant for quite a chaotic environment. It also was quite difficult doing ward rounds, because wherever you go, there's patients. Now, this taught me a great deal about medicine, but the career plan did not go well. So when I was in Uganda, I became very unwell. I got dysentery, then renal failure, and then respiratory failure. And being ill in that setting is not good. So I was airlifted out of Uganda into Nairobi and then to England. And this is a photo of the little aeroplane that took me from Kizizi Hospital out to Nairobi. And over the next few weeks and months, I was very ill and was in and out of intensive care for quite a number of months. But this is quite interesting. I found that often in the worst experiences, I've learnt the most. And I think that's true of this as well. I knew that I might not survive, but these experiences taught me what I could rely on. So I was a medical student in Oxford. I'd got loads of friends, great, lovely family, but none of that would last. And it really just taught me what will last, what can I rely on. So there were some very useful messages, I think. So, as you can see, I did survive, but the career plan had to change. So on to clinical training now. I decided to train in oncology, and so here I am. This is a cartoon done by, I think this was David Dodwell's radiographer helper in clinic. This is a cartoon of me, and it typifies my experience in oncology clinic. So look at that in pile. I was quite obsessive about doing my paperwork well. And it works in research to be obsessive, but it didn't work very well in the clinic, and it just meant things took a long time. So I used to get very big piles of my in-tray. David Dodwell's job was really busy, so my bleep was always going, and chocolate cake here on the right was essential. We ate a lot of chocolate cake and had a lot of fun. Now, in those days, junior doctors worked quite long hours. And as a senior house officer, often it was about 120 hours in some of the weeks. And we all learned a lot about how to treat patients. But it also taught us other lessons too. So I thought I would reflect on a couple of those. The first thing was how to keep smiling when everything else is going wrong. So my patients needed me to be smiley and positive. And I think the second lesson was stubbornness. How to make something work against the odds. And I think many of us have been in that situation in the clinic. As junior doctors, you try really hard to get things to work for your patients, often against the odds. And those were useful lessons. And also, I wanted to mention on this slide several oncologists who've really helped me, and I've learned from them. And the first is David Dodwell. I was his registrar for a few years up in Leeds. And he taught me how to stay calm and positive, even when things are going wrong. And it's not easy when things go wrong in the clinic. So that was a useful lesson. The second one I wanted to mention is Bernadette Lavery, who's not here, but she'll listen to the recording later, who has the wonderful ability to see the best solution for every patient. She's got very, very calm and incisive brain. And Saleda also, who's great at making things better in radiotherapy and in research. And also the Oxford oncologist row there, you've really inspired me with your questions. So thank you to you. So these are my holidays, a change from clinical medicine. I decided to do catering in my holidays. It was very different from being on the wards, and I cooked for 200 teenagers on Christian holiday parties. And here is me making the icing for a cake, and you can see this kind of white stuff. That's all the icing sugar which is coming out the bowl. I think that's why the photo was taken. But catering taught me similar lessons as well. How to keep smiling when somebody's added twice the amount of curry powder to your curry. Be stubborn, how to sort something out when a meal goes wrong. So those were useful lessons, but also fun. We had such a fun time. Now back to clinical work. I was trained to treat patients with cancer, and as I did this, I kept on coming across problems that I didn't know the answer to. And then I found that nobody else knew the answer either. And this is just one example on this slide. So in the past, we didn't do scans to guide our radiotherapy. This is a patient who's having radiotherapy for early breast cancer. And what we did was we drew on the skin with lines. This is before most people's time, I think. So there's a box here to treat these lymph nodes. There's a box here to treat those lymph nodes. And there's a box around the breast. And you couldn't really see what you were doing. And then in the early 2000s, we started to do scans of people before their radiotherapy. And so this is a CT cross-section of a patient. I'm going to take you through it for people who aren't familiar with it. So this is what you would see if you slice through a woman that way. And it's as if you're looking from the patient's feet upwards. So there is the right breast, there's the left breast, there's the backbone, and the heart is in the middle, and these either side are the lungs. And the radiation dose is shown by the colour on the patient. So the breast is getting some dose, and these nodes here are getting dosed. And this is approximately what you would see if you gave those radiotherapy fields. Now, when we started seeing this, we realised we didn't know does this matter to irradiate the heart? What are the risks of this type of radiotherapy? And we realised that we couldn't quantify those risks for patients in the clinic. And I remember as a young registrar sitting in David Dodwell's clinic talking to patients about it. And for some patients, we just didn't know if their benefits were bigger than their risks. And there were other questions like this also that I didn't know the answers to. And so one day I was sitting in the hospital library browsing, and I came across some papers written by Sarah Darby and Paul McGale. And they just seemed to make sense, and they were working on this. So that's where Sarah's bit of the story comes in with David Foreman. I really wanted to come and work here. So I approached Sarah, or David approached Sarah, in 2003. And this is when we were in the Gibson and Harkness buildings, happy days. So I was interviewed here for a job by Sarah and Paul. And one thing came across to me very clearly, and that is they loved analysing data and doing it really well and getting results that could be used by clinicians like me in the clinic. And then after my interview, we had lunch. So we had lunch with Richard Peto and Paul McGale. Now, those of you who know Richard and Paul can probably imagine, oh, here he comes, just the right moment, Paul. You're about to be on screen.
Yes.
This is our lunch at my interview at CTSU in 2003. So this is what we talked about. Actually, this is what they talked about for 2 hours. Spiral galaxies. And so I was just slightly nervous about what I was letting myself in for coming to work in CTSU, but I have to show you this. Look at that. That's Paul McGale's photo. Is that from your back garden, Paul?
Yes, yes.
It's amazing, isn't it? Richard told me yesterday what all the different bits were, but I've forgotten. Anyway, so I enjoyed my interview. I wasn't sure what I was letting myself in for, and the next week I went on holiday to this beautiful beach, and this was my reading material. I knew I needed to find out about the universe and galaxies if I was to work here. So, we've now come to 2004, the wonderful year when oncology gets together with statistics. I did a DPhil with Sarah and Paul as my supervisors, and it was interesting and exciting, and actually for me, my hobby became my job. So what I did in the evenings and weekends, suddenly I could do it all day, every day. It was really exciting. And I loved it. So let's get back to the problem of radiotherapy. And, oh, hang on, before we do that, Sarah Lewington is here today. And Sarah was my office mate, and she is a really good example of the benefits of mixing up people from different teams. So I don't work with Sarah, but we shared an office together, and I learnt masses from her during my first few months here in CTSU. I learnt how to do a talk, how to do a PowerPoint, just lots of other kind of practical fun things. And that and many other things made my first few years here very fun. So this was the problem that I came to tackle, the problem of radiotherapy in the heart. And we'll start off with where Sarah and Paul had got to without oncology input. So what statisticians could do without oncology help. And so we'll start with EBCTCG. So Sarah and Paul worked in EBCTCG, and so that stands for the Early Breast Cancer Trialists Collaborative Group, which was started by Richard Peto in the 1980s, and this is Richard Peto's slide. And what the EBCTCG does is bring together all of the worldwide randomised evidence in early breast cancer in large meta-analyses. And why is this so useful? Well, because it enables reliable assessment of moderate differences in long-term survival. And to do that, you need large-scale randomised evidence, preferably many, not few thousands. And you need all the main trial results available. And this has been very successful over the past few decades. It's really helped oncologists in the clinic. And it involves all of the major breast cancer trialists from around the world. And this slide says it all really. These are the EBCTCG collaborators. And this shows where Sarah and Paul had got to before I arrived in trials of breast cancer radiotherapy. So it shows data on 40,000 women in 75 randomised trials where women with breast cancer were randomised to radiotherapy versus no radiotherapy. And Sarah and Paul and others had found that breast cancer radiotherapy increases the risk of death from heart disease. So there's heart disease and there's the rate ratio. Now, radiotherapy has improved since those trials were done, and less of the heart is in the field. And so the risk today we knew would be different from this, but we couldn't quantify it. And that presented a problem for oncologists. So there's me, an oncologist, thinking about my patients and wondering what are the benefits and risks of radiotherapy. And what we oncologists needed was a dose-response relationship. And that would tell us the risks from different radiation doses. And so that's where I came on board. My job was to calculate doses to the heart for women irradiated in the past. And I did that with the help of Andy Nisbet, who used to be the radiotherapy physicist across the road. And this slide shows some of the regimens that I reconstructed. There were, I think, about 200 of these, so I've just shown a selection. And at the top, you can see a CT scan. It's a bit like the one we saw earlier. So it's what you would see if you sliced through a woman that way. And it's as if you're looking from the patient's feet upwards. And the colour shows where the dose goes. So the top is typical of 1970s radiotherapy, and then the middle, typical of 1980s radiotherapy, and then at the bottom, 1990s radiotherapy. And this slide shows quite nicely what's happened in breast cancer radiotherapy over those 30 years. Now, there were a number of challenges in this. At the time, nobody did this type of research. So I kind of had to sort these out for myself, but I was helped by those lessons from the clinic. Keep smiling and be stubborn, and also those lessons from catering. I had to work out how to do it. And my first challenge was the software. So the only way of doing this was to use the computers that we used in the clinic at the time. And they were not used to dealing with large-scale radiotherapy data. And that caused considerable challenges. The main one was I crashed the system one weekend, so everyone got in Monday morning and found they couldn't treat any patients. It just struggled to cope with the sort of work that I was doing, and I had to think out of the box, think of different ways of working. The second challenge was working at night. So the systems were all in use all day, every day in the clinic, and there wasn't capacity to have an extra person using one of those old Helax computers. So I worked at night. People left the unit at 5 and I'd come in and start my work. And those of you who worked in the old radiotherapy physics building might remember these. Yeah. And these came out at night. So I had lots of cockroaches to deal with. And I learned not to wear flip-flops. Luckily, for anybody who's wondering, that building is not in use anymore. Physics has moved. And also the old techniques. So many of the techniques were for 1950s and 1960s. And that presented some challenges too. But it was quite fun. And it was really fun to be trying to think how to do stuff outside the box. It just made it exciting and challenging. So I produced thousands of radiotherapy doses from the work. And when you have radiation doses, you can do something like this. This is a dose-response relationship. So on the x-axis, you've got heart dose here in grey, and on the y-axis, percent increase in major coronary event rate. And you can use this in the clinic to calculate the risks of different radiation doses to the heart. And this has been really useful. It's now used to assess the risks of modern breast cancer radiotherapy. Now, I can't go past this slide without talking about Sarah and Paul, Sarah Darby and Paul McGale, because they really were the brains behind this. And I've learned so much from both of them. So here we are. Paul, and many of you know Paul, he's got the most brilliant brain, and he often sees things that the rest of us don't see. And working with him has taught me to think really carefully about data, and it's also been really fun, you can imagine. And Sarah's been an excellent example to me of somebody who doesn't give up. She keeps on going until she gets the right answer, and she doesn't get in a flap about it. And that's been great, a great example to me. Plus, they're great people to work with. So they've kept me cheerful and positive for the past 2 decades. And their studies have saved the lives of many patients with cancer as well. So more team members joined. We had help from a cardiologist for this next section, Kazem Rahimi, who many of you will know. And his input meant we could estimate the risks of irradiating different parts of the heart, not just the whole thing. And this image here shows a representation of the heart from a CT planning scan. And that's the reason it looks a bit wiggly. Can you see these lines here? These are the coronary arteries going down the outside of the heart. And they look a bit wiggly because of the breathing artifacts. And what we were able to do with Kazem's help is to look at the risks of irradiating different parts of the pink left ventricle and different parts of the coronary arteries as well. Now, in order to work out which parts of the heart were damaged by radiation, we needed to look through patients' cardiology notes. So then we could assess the relationship between radiation dose and the risk of damage. And as part of the pilot, I went down to the hospital basement and got out cardiology notes and looked through them to see what information I could find on parts of the heart that were injured. Now, I had the same problem as before. The clinical systems were all fully in use in the day, and so I had to work at night. But this time there were no cockroaches, so it was much easier. And here's a typical set of cardiology notes. I read these notes to find out which parts of the heart were damaged, and note the essential tool in the night abstractor's armoury, a cup of coffee. And then using all of that information, we could find out the relationship between dose and damage for different parts of the heart. And we showed that dose was associated with injury for all parts of the heart, which actually is a really nice message if you're an oncologist, because it means you don't have to contour all the little bits of the heart to estimate the risk for a patient. So that was just what we wanted to hear. Now, I've touched briefly on the work of EBCTCG, and during the past 17 years, I've worked with Sarah, Paul, Richard Pito, Richard Gray and Robert Hills and many others in EBCTCG, and I've learned from each of them. So Richard Pito and Richard Gray have been excellent examples, I think, of what to do when oncologists want to do the wrong thing, which quite often happens, and how to do it with a smile and without any crossness. And I'm continuing to learn from Robert Hills, whose leadership continues to make EBCTCG produce very reliable and good meta-analyses, And I'm going to present to you just one example of what we've done together in EBCTCG, because it shows you what you can do with teamwork. And EBCTCG is a very coherent team which works well together. So here we go. It also shows how long it takes to write a good paper. So this slide summarises the history of one of our EBCTCG papers, the Radiotherapy Side Effects paper. And we worked on this paper for about 20 years. It started in 2000 to 2004 with Sarah and Paul and others doing the basic analyses. Then I arrived in 2004 to calculate heart radiation doses. And after that, we decided to look at the risk of lung cancer from radiotherapy too. So I calculated radiation doses, and then we thought, how are we going to make this relevant to women today? Let's see what doses the organs to get in modern radiotherapy. And then we had this really protracted 3-year period of kind of submissions and bounces before finally getting it published in 2017. And this was the main finding in the paper, and it's the one I think that will be most useful in the clinic. It shows the estimated 30-year risks of getting lung cancer as a result of radiation. It's really beautiful, so I'm going to take you through it. So on the x-axis here, you've got age. So here is the woman when she's age 50, 60, 70 and 80. And on the y-axis, cumulative risk of lung cancer death. And so let's first look at the non-smoker. If she doesn't have radiotherapy, she follows this kind of yellow line here. And her risk of dying from lung cancer before she reaches age 80 is just 0.5%. Now, if she has modern breast cancer radiotherapy, her risk goes up to 0.8%. The increase is absolutely tiny. Now, let's look at the smokers. So, if a woman has smoked since adolescence and continues to smoke, she follows this line up here. Her risks are much higher. And if she has modern breast cancer radiotherapy, the risk goes right up here. So the risks down here are much lower than the risks up here. So a 50% increase gives a much bigger absolute increase for the smokers than for the non-smokers. And this was really useful, and it's changed practice in many places. And women who now come for breast cancer radiotherapy who are long-term smokers are advised to give up smoking. And I think this slide illustrates nicely the bonus of working in a department with others to produce really nice results through teamwork. But inevitably, they take time to get right. So that figure took about 17 years. And this slide, sorry, Rosie, this slide illustrates some of the feelings that Paul McGale and I had along that 17-year journey. So this is my daughter a few years ago, the optimist saying, we'll get there. And this is my son, the expression on his face. It's taking a very long time. We had our ups and downs, didn't we, Paul? But it was worth it in the end. And that paper provided a very exciting opportunity to be on Radio 4. That was fun. Just a short 10-minute interview on Inside Health. And this is what has happened to breast cancer mortality since the 1950s. So here we've got the 1950s, 60s, 70s, and so on. And on this axis, we've got the risk at age 35 of dying from breast cancer before age 70. And if you look at the UK and the USA, they both steadily increase up to about 1990. And then after 1990, breast cancer mortality has steadily continued to decrease, both in the USA and in the UK. And part of that is due to improvements in breast cancer treatments, and part of it is due to some of that will have been contributed to by the work of the EBCTCG, and also the excellent team who work in the Cancer Overviews office. So Liz McKinnon runs an excellent team who provides support without which these meta-analyses wouldn't happen. So I've shown you some of the highlights of what's gone before. What about the future? So here we are in the Richard Dole building. My team has just received 5 years of funding from Cancer Research UK to estimate the absolute benefits and risks of breast cancer treatments. And this is me as an oncologist trying to work out what are the benefits and risks. And our work is going to help with some of this. And one of the things that our work illustrates nicely is that mixing statisticians and oncologists can produce very useful results. But it's also really fun. It's a really nice team. So this is our social last year in my garden. And we'll all be in David Cutter's garden in about 2 days' time. It's a lovely team that work really well together. And here is the mixing of statisticians, clinicians, and alcohol. This is one of the, do you remember the old CTSU socials? This was Lady Margaret Hall about 10 years ago. And so working with oncologists is fun. Working with statisticians is really fun. I'm not sure how I managed to get 3 wine glasses. But working in this department is a real privilege. It means producing research which is high quality and which saves lives, even if it does take a long time sometimes. And working with a group of people like this is a real privilege. So now, when Richard Pito heard that I was doing an inaugural lecture, he gave me 2 pieces of advice. He said, what was the first one? Don't tell any jokes was number 1. And the second one was don't thank people. But I might be about to disobey him. So these are the teams that I've worked on. I wanted to finish with my teams because much of the work that I've shown on the slides is thanks to the care and attention to detail of the people on these slides. And there's many disciplines on these slides. There's oncologists, statisticians, support staff, systematic reviewers, and they're all essential in the research. And so the work wouldn't have happened without them. And I'm going to finish with my family. So my husband Bruce has shown amazing patience over the past 15 years as I've worked to multiple deadlines, particularly over the last year with a Cancer Research UK grant deadline. Rosie, she's always smiling, whatever's happening. Actually, you don't need to learn those lessons, you already know them, you're always smiling. And Peter, probably the kindest boy I've ever met. And here we are on top of Latrig in the Lake District, a very windy day. And so thank you for listening.
Now, because it's an inaugural lecture, there are no questions or answers, but Richard Peter is just going to say a few words. So let's sit over here.
I thought that was great, and it just shows that, but you've got to be really motivated. You've got to want to answer the questions, and that's what Carolyn came with. She came wanting to answer the questions, and look at the effort. I think it's just beautiful. When people talk about alternative medicine, I mean, the contrast between this sort of knowledge and, the knowledge of alternative medicine is so total. And it's one part. I mean, there's the parts involving systemic treatments. Again, they've taken decades to get right. The techniques of surgery and the methods of actually getting patients safely through surgery and supporting them afterwards without, the patient dying from surgical complications. It's all just taken so much work. And actually, if you got that breast cancer mortality graph, Hongchair ran it going to 2019, then actually now there's a 60% reduction in breast cancer mortality in middle age. So it's been keeping on down in the 4 years since the graph you've shown was last available. And, well, thank you very much from all of us. And also thank you very much for some of the patients whose lives you've saved without them knowing it. And I believe that wine is available outside for, obviously, would be suitable for the speaker. And it's probably suitable for the audience as well. So I should say, no question. Oh, I have to say,
Before that.
Is there something else I should have said?
No. Thank you, Richard. Before that, we have to thank Carolyn and present her with this token of appreciation from the department. So, Carolyn,